Hello, I'm Dr. John Kruse, and welcome to today's question and answer hour. So I will attempt to answer the questions on videos that I've released this past week. There's one new one and one resound recording, or sound editing. And I'm also open to other questions on ADHD and even questions on the broader topic of mental health in general. Before I summarize the two videos that came out this week, I will mention that 2 weeks from now, on July 15th, I will not be here. I'll be traveling for family reasons and supposedly in a location where there's not good internet hookup. So next week I'll be here. The following week there will be a gap. So the two videos that came out this week, one was on methylene blue and ADHD, and the other was on left brain, right brain, what's the real differences. So with methylene blue is a dye used in fabric and paper industry that's been around for 150 years. It's also early on was picked up as an antibiotic, and from its effect on biological tissues, they explored more of it became widespread as an anti-tuberculosis agent and an anti-malarial agent, and it was the response. And from that, it led to discovering other properties of it. So it's very good at moving electrons around. So it is the standard treatment for methemoglobinemia, where the hemoglobin molecule loses an electron and can no longer carry oxygen around the body. Might be going into too much detail for a summary here. It's also known to be a monoamine oxidase inhibitor. Right now, it is one of the surging drugs in the biohack, nootropic, take care of your brain industry, based on some basic science research. Again, it does have monoamine oxidase properties. It does have anti-inflammatory properties. It is good at helping reduce oxidative stress or damage in the brain. It does seem to boost mitochondrial function in other ways. Dosage does seem to be critical for this. So some of its properties do change as the dosage increases, and not just get stronger, but even flip 180 degrees. And the data in humans is pretty paltry at this stage. So I'm not saying it doesn't work, but in terms of mental health issues, there's a handful of studies looking at it for bipolar depression, one study looking at it for Alzheimer's. The Alzheimer's study, which went on for a year and maybe the closest overlap with ADHD symptoms, only found improvement in the middle dosage range, not in the high or the low range. So this may be helpful. Again, dosage will be critical, but in terms of any evidence that it's directly helpful for ADHD is, I would argue, way premature. And given its potential monoamine oxidase action, there is a potential for dangerous interactions with other drugs and with certain foods. So the second video that was re-released was on the left brain, right brain, and drawing heavily on the writing of Ian McGilchrist, who's written about differences and wants us to think more subtly about left brain, right brain differences. And it's as much about how they function as in terms of what specific tasks they do. So it's not as simple as left brain, verbal, right brain, artsy-fartsy, creativity. It's more that the left brain is granular and logical and deductive, breaking things or scenes into focusing on little parts. And the right brain seems to be much more holistically integrating things, and the two hemispheres ideally should be working together. And although there is some good data that there is some lateralization of these functions, I would say McGilchrist isn't making the claim that the left brain does one thing and the right brain does the other. His bigger argument, and this is my interpretation, is that there are two very different attentional processes. One sort of, again, this granular looking at pieces, and the other much more holistically. And these may have evolved from avoiding from being a meal to which you need to scan everywhere to how to get your own meal, which is focusing on specific tasks. And that, as far as we can know, except in some unusual circumstances, we only have one form, one aspect, or one conscious entity in our brain at a given time. And these two hemispheres or two approaches may be vying for control. So that's the summary. And I see there's a whole host of questions already and some familiar faces. So I will try to jump into it quickly. Hello, Dennis. So Dennis asks, what prevents some autistic people from being able to speak? That a lot of that is more than I don't know how much we even know, but I know that I am not at the forefront of autism research. So my thoughts will be partial. I mean, one, I think it's pretty clear that the inability to speak is sort of at one end of severity of autism. Certainly people at the milder ends of the spectrum have minimal difficulty with enunciating and articulating and engaging in speech. But given the social deficits are one of the central features of autism, and it's not, again, it's not shyness, it's not social anxiety or being anxious in social situations, it's not perceiving social information and communicating it the same way. So whether not speaking is just a constellation of things that are the more severely social systems are impaired, or whether it's more a specific subset or focus on one angle or symptom of autism. And again, this is my limited knowledge, but from what I'm aware of, I'm certainly have met individuals who are so significantly impaired that they could not generate much, if any, speech at all. What's interesting is that they seem to retain more of an ability to comprehend speech. So that would suggest some differences between Broca's areas and Wernicke's areas of the brain in terms of differences between perceiving speech versus being able to articulate or generate speech. So I can't say more there. So I'll just stop. Hello, James Alexander, who asks, why are dermatology and ophthalmology seen by medical students as high-paying, cushy lifestyle residencies compared to psychiatry, with these two being basically the most competitive programs to get into? What is your opinion on the earnings and lifestyle private practice psychiatrists relative to dermatologists and ophthalmologists? Does psychiatry have any advantage over these fields when it comes to these two considerations? So my thoughts are going to be a little bit highly idiosyncratic and old-fashioned. I still think medicine, or see it as a calling rather than a career or money-making mission. Certainly, most doctors are paid above the mean for the US, so it is generally a comfortable lifestyle in terms of income. But in terms of just the minutes of interaction, I mean, dermatologists have lots of interventions, so our basic system right now is paid more by doing something rather than by just listening and/or prescribing. So specialties like dermatology, where you can use your cryostat to remove 13 precancerous lesions or warts, I mean, you get paid for doing things in our system. So it's dermatology is substantially more lucrative. I think eyes are valued because vision is so highly centered in our society. So particularly are there dangers in dermatology? Yes, there's some people who get a Stevens-Johnson reaction, which is essentially lesions that are third-degree burn like can develop over the body and you can die from it. But usually a dermatologist isn't even the primary person you're calling in to treat or deal with that. And usually it involves stopping a medication. So part of it is how likely is someone, and there are, how likely is someone to be called in outside of office hours, or how urgently are their services going to be demanded? It's fairly low compared to the rest of medicine for dermatology. With ophthalmology, most of the work is routine, but there certainly are ophthalmologic emergencies like retinal detachments or something that has to be dealt with quickly. Some people have claimed that in psychiatry there's no emergencies. I mean, certainly patients can have bad drug reactions. Patients can have panic attacks, which feel like emergencies. And certainly suicidal thoughts can be urgent and life-threatening. So, but again, most dermatologists, most ophthalmologists are working a relatively small number of hours. Under highly controlled situations without much intrusion into their life outside of those hours, depending on how individual psychiatrists deal with calls or complaints or individual sessions with patients, that can affect lifestyle. But to me, again, I see medicine more as a calling than as a career. So to me, you should be doing something that's really interesting to you. If skin or eyes don't really turn you on, then I think over time you're far more likely to get burnt out or unhappy or dismayed or resentful of what you're paid or what your hours are or how much your colleagues are helping out with call or whatever it is. And if you're enjoying what you're doing and seeing it has a positive impact on people, then it's more likely to be sustainable. So I don't know if I'm answering. I don't know this precise data on earnings. And I think lifestyle, again, there can be certain demands of a practice, but different individuals have different ways of dealing with them. I mean, I have some weird ways. So my work phone is my personal phone. And partly because it's always been that way for more than 30 years before cell phones became ubiquitous, I tend to leave my phone here at the desk when I'm going outside and hiking and doing things outdoors or away from home. That helps my peace of mind. And again, my patients know that even though I'm highly responsive, I'm not usually immediately responsive or available. So again, even given the demands of a certain profession or professional niche, there's a lot of ways an individual can shape their lifestyle to accommodate or not accommodate that. So I'm happy to try to answer more on that. And again, this is highly my opinion and my experience. Nell, N-E-L, I think is asking what's the best drug overall for depression and anxiety if the patient is adamant. I think it's adamant against taking SSRIs due to sexual side effects. So if worry about sexual side effects is a primary driving factor, Wellbutrin is one option. So Wellbutrin, and I have a video on this, is a good approved treatment for depression. Doesn't work for everybody. It can commonly increase anxiety, but if the anxiety's origin is coming from the same origin as the depression, very often Wellbutrin effectively treats anxiety as well as depression. So again, unlike some of our other antidepressants, which have very low likelihood, particularly after the first few days, of exacerbating anxiety, which Wellbutrin can do in some individuals, it can also treat highly anxious depression. So, and has zero compared to placebo risk for sexual side effects. The SNRIs tend to have lower rates of sexual side effects because the norepinephrine component seems to be countering that, and particularly the more noradrenergic you go. So as you move from Effexor, which is venlafaxine, to duloxetine, which is Cymbalta, to milnacipran, which is Savella and Fetsima, you are relatively bringing on much more norepinephrine relative to serotonin reuptake inhibition, and therefore the likelihood of sexual side effects diminishes considerably. Other antidepressants, so Remeron, mirtazapine, has low rates of sexual side effects and can treat depression and anxiety. And I would say the number one, particularly for treating depression and anxiety, and it's very seldom used, partly because it's in a class by itself, is nifazodone. So that's quite effective for anxiety, quite effective for depression. And because of how it's acting on specific serotonin it has only weak serotonin reuptake action at the highest doses, and it seems to be more specifically working on subsets of serotonin receptors, but very low rates of sexual side effects. Max, hi, is asking, do I think mental health has a role in the dropping birth rates around the world? Do I think mental health has a role? I'm a little confused as to whether should mental health have one is we know the biggest factor for decreasing birth rates seems to be twofold. One is as medicine penetrates Western medicine, which does have its problems and imperfections, but markedly improves the lifespan, particularly of, historically, lots of children died in early years before they ever became adults. The better medicine has penetrated given society, the lower the rate it is, the more likely you have kids that will live into your own adulthood and senior years, the less imperative, at least at one level, for having lots of kids. So overall health certainly has led to decreasing birth rates, and the other is access to contraceptives. So even where birth rates or survival rates have increased, if there isn't adequate access to sources of contraception, then birth rates still remain high. I think it's, so I have a strong, I care about the earth, and it's just simple fact that the more individuals we have, the bigger impact we have, and most of humans' impact on the earth in natural ecosystems is damaging. Does it have to be as damaging as it is? No, but is it damaging and disruptive by its very presence and numbers? Absolutely and irrefutably. I'm completely baffled by people who have some degree of intelligence, like I'm getting more into politics now. People worried about population shrinking, and Elon Musk has repeatedly made the argument that there are certain things like maybe his Mars project that can only happen if you have a certain minimum number of individuals on Earth. You're not going to be manufacturing cars if you only have 100 humans on Earth. At some degree, some of those arguments make sense, but I am not aware of any great endeavor that's possible with 8 billion or 20 billion people that would not be possible with 20 million people. So I think we have so far surpassed any total number that's a critical mass for engaging in any complex, sophisticated projects that arguing we need to keep going bigger is ridiculous. Arguing that progress or growth or human quality of life is only enhanced by more and more rather than finding something that's good and sustainable just seems ridiculous. Anyway, so I'm not sure if I'm addressing properly or getting at your question. So certainly follow up if I'm not. And again, those were political and psychological and philosophical discussions rather than science, but I'm happy to engage in them. And I would argue my views are science informed on that. So Retta asks, does the corpus callosum get fatigued? Does underdevelopment of the prefrontal cortex and ADHD create an extra burden on the corpus callosum? So one is the corpus callosum is a collection of fiber tracts. So I would argue, I mean, there might be demyelination states or something like MS or other conditions which might make it easier to fatigue or damage functioning across the corpus callosum. But if we're talking about fatigue, we should be thinking more about the cell bodies that are projecting their axons across the corpus callosum. So I don't know of any mental health or neurologic health condition where impairment of communication across the corpus callosum is a primary driving factor. Yeah, so, and does underdevelopment of the prefrontal cortex and ADHD create an extra burden on the corpus callosum? I mean, the brain is complex and interconnected, and I will leave it at that I'm not aware of any specific burden that it would place there. James Alexander asks, do I think that some cases of ADHD patients functioning declining after their diagnoses are actually due to them realizing just how many areas of life they've neglected up to that point and struggling to try to fix them all at once? One person I knew pretty much exclusively focused on trying to get through grad school, on neglecting their social life, health, wardrobe, and so on. And after their diagnosis, claimed to be getting worse, and this seemed to be the actual cause of their subsequent distress. So I'd certainly seen, I think I've seen sort of what you're describing. I would maybe frame it a little differently, but that awareness of ADHD can make someone more aware of their impairment, and it could make them, by focusing less productively on areas that they can change or alter, could contribute to some extent to further worsening overall functioning. But yeah, I'd say that hopefully whoever they interacted with to gain a diagnosis is also helpful or adept at helping redirect their energies and providing either medical or non-medical medication tools to help improve some of the functions that are getting them off track and preventing them from getting back on track and productive. So Max is thankful. Thank you, Max, for providing the link to the Wellbutrin and also putting in the reminder that the information I'm presenting is not specific medical advice for individuals. It's general information. Hopefully it's true and accurate and helpful. But since I haven't evaluated any of you, it's not fair or ethical or reasonable to be taking what I say as a specific recommendation. Scooty asks, are the neuroplasticity benefits of stimulants only seen in children, or can adults benefit as well? So one, I'd like to qualify things, and so one is, yes, we know stimulant drugs can induce plasticity. Do we absolutely, have we nailed down that allowing for greater plasticity is what allows for healthier growth of brains? I would argue that the connection, is absolutely sensible to me. It seems to be highly likely, but I don't know of too many situations where we've actually nailed down where neuroplasticity is definitively part of the mechanism for improved functioning. Um, so, in general, kids have more neuroplastic or brains that are able to function or change with input and change their ongoing connections and functioning. But I think there is clear evidence adults can too. So I would jump over to some of the work by Amy Arnsten and colleagues at Yale, in particular looking at things like guanfacine, which allow greater synaptic plasticity in prefrontal cortex, and that doesn't seem to be restricted to children. So that's again guanfacine. That's not necessarily a stimulant induced neuroplasticity, but it's speaking to the topic of neuroplasticity and change even in adult brains. And some of the conditions we're looking at are things like post-COVID and MS and other conditions where there might be brain changes induced by a more clearly biological origin. So James Alexander is, have I come across or heard of permanent side effects from ADHD medications like stimulants, SNRIs, and alpha agonists other than psychosis-induced schizophrenia? Are there any speculative long-term risks, for example, stimulants increasing Parkinson's risk, which you'd think are more likely than not to eventually be confirmed by science? Again, one of the huge difficulties is that presumably, and I know there are people who are against any biological understanding. I think it's firm and clear that conditions, whether they're schizophrenia, ADHD, depression, have some underlying basis in a brain that's behaving and working differently. And what's really difficult is all of those underlying changes for the condition are probably predisposing people to certain long-term health consequences. And that's separate from whether conditions like Alzheimer's and other forms of dementia are almost certainly reflect a biological process that's going on for 30, 40 years or more before we're seeing much robust evidence in terms of behavioral symptoms. So it's really hard to sort out the confounding. So that's one level of confounding variable. The second is we know a whole host of environmental factors, from poverty to having extensive viral infections, also can change brains over time, and that having certain mental health conditions makes you more likely to have certain of these environmental detrimental factors. So again, separating out over time whether a long-term consequence is the mental health condition itself, whether it's associated confounding factors that are from the very beginning strongly associated with it, or from the specific actual treatment. So to me, is it plausible that messing with norepinephrine and dopamine neurons with a stimulant may have effects on the likelihood for Parkinson's over time? I think that's plausible. But again, I think even the evidence we have, which has tried to separate out sort of some of the diagnosis-based issues and some of the confounding variables, again, I don't know that there's any conditions which I can definitively say we have the evidence for. What else would I think we might be more at risk for? Yeah, I mean, what I would argue or hope or think is that in general, if someone's functioning better in life through medication interventions, separate from the direct improvement in symptoms, that I think there is likely to be positive feedback, one that they're likelier to make healthier choices, or likelier to have, again, less of these other environmental exposures over time. They're likely to have either greater income or greater social connections or feeling better about themselves. So I think there's likely to be positive feedback loops or vicious feed forward positive cycles that are having beneficial effects for brain and body health over time when we get the medications right for a given individual. So, I mean, with things like the SNRIs, there's some evidence that, risk of osteoporosis is higher and risk of certain cancers might even be higher, but those tend to be relative risks in time. So one that gets a fair amount of attention and it's not quite negligible is risk for coagulation and clotting and bleeding disorders. So being chronically on SSRIs doubles your risk of getting a bleeding ulcer, but so does taking aspirin or NSAIDs doubles your risk, but the overall risk is still pretty small. It goes from about 1% in the general population to about 2%. Is that a meaningful difference for most people? Would you say, don't buy a lottery ticket if you have 98 versus 99% chance of not winning? Is that a meaningful difference? I would argue at a population level, absolutely. At an individual level, completely meaningless. So there. So I'm not sure which question Dennis was thinking was a good question, and hopefully I've answered adequately. And again, I'm happy for anything I've just been spewing about to try to recalibrate or precisely answer part of it. Max is forwarding question from the Reddit site, so I'll also give a shout out to the Reddit site. That it's a place there for people who are on this channel or are interested in what I write or think about to comment on each other's comments. So Significant Club was appreciative of this week's videos and asks, I don't know much about Ian McGilchrist, but what is he proposing to treat autism? So McGilchrist's own writing, at least in the, forgetting the Master and His Emissary, and he's written, which is a several 100-page dense book. He focuses much more on schizophrenia than on affective disorders or on autism or other conditions. So that's been more of his research interest. He's actually a fascinating individual, and I might get some of the slight details, but he had a degree in literature and was teaching literature at Oxford before he went back to get training in both in neuroscience and in psychiatry. So he brings a wealth of information from different perspectives, but my impression was his discussion of autism was fairly limited, but he may well have well-developed thoughts on that in terms of treating it. So James Alexander wants me to talk more about question from last section. When you run into ADHD denial among other psychiatrists in their clinical practice and in their academic pursuits, what does it sound like? In what cases have you ended up arguing with an ADHD colleague? So and his last name is Gamani. He's one of he has an academic position. I'm forgetting his first name, but he's one who has been more willing than others to publicly, flat out claiming ADHD doesn't exist and that it's all affective disorders, depression or anxiety. He's also an academic who has made his career by taking somewhat provocative, and I think on some issues he's quite right, but the ADHD just seems so nonsensical and devoid from actual experience with patients. So one area is getting into, are these people really treating individuals, or are they more academics who are doing research? And there's certainly academics who do see some patients. And the danger of arguing from examples is that it is unscientific. So if I can say in this individual, there's no evidence of a mood disorder or sadness or emotional numbing or irritability, and it's purely executive function symptoms they are displaying, and they respond to these medications, which aren't traditional antidepressants. So one, if I'm arguing from specific examples, then that's anecdotal evidence. I mean, one anecdote can refute a theory if it, but in terms of, in general, what is going on with ADHD, or in general, what's going on with mood disorders, it's not a very effective argument. Part of it is if you take the time to explain, and I'd say still in this day and age, psychology, I think, there's a tremendous body of important research, but it's still interesting how often neuroscience sort of trumps it. So psychologists can do all sorts of testing and demonstrations and looking at what executive functions tend to be clustered together in ADHD, or looking at some of the parameters. But until you actually show, oh, this is happening in the prefrontal cortex, somehow that makes it more concrete and real to so many more people. So part of it in getting people to understand who don't want to accept ADHD is exposing them to some of the research and some of the tie-ins to neuroscience and brain function can be helpful. And again, I think part of what also holds us back is our current mental health diagnostic system. And I think we will be moving much more into, whether we call it a condition, a disease, an entity, or a set of clusters or what. I think a central focus of what we now call ADHD will be on prefrontal executive function circuitry and impairment there. And even though certainly in depression, that's frequently or often involved, I would argue that the way we think of them and people think of themselves is to focus more with depression research and clinical understanding on the emotional, the sadness, the lethargy, the anhedonia, the inability to initiate things, the excessive guilt, and other, as well as sadness. I think there's an emotional sadness core to what we will be calling, or what we may not be calling, depression in the future. I don't know if I've lost, but the question, can you have autism and OCD and ADHD? So yes, you certainly can. And again, one of the most well-documented findings in mental health research, getting back to our diagnostic criteria, is if you have one condition, you're substantially likely to have more than one condition. And whether that's, again, means, some have argued, and I have a talk on this and an article on Medium, whether it's more meaningful to say there's just one general psychopathology factor and that there are multiple flavors it can show up in. To me, I think that loses important distinctive value. But yes, you can have all three of those conditions together. Probably some of it is common genetic predispositions increasing the likelihood to all of those conditions. And again, I do have talk on OCD and ADHD, I believe. Part of those at surface may seem opposite. And again, part of it may reflect lack of control over lack of control over, how am I going to express that? I'm not going to express that well. They may be flip sides of the same coin, but that might mean they're reflecting the same target circuitry in the brain, may have problems functioning according to human norms. The other thing is that OCD symptoms may well be compensatory to try to make up for if someone knows that they're often late because they have trouble with time. They may become obsessively focused on leaving early, being prepared, never being late, so they can't be blamed for it. So they could develop an obsession about time management that to directly counter or treat their propensity to be late. So Max has forwarded another Reddit question, this one by Designer's Study. Could a proper understanding of left and right brain differences lead to better mental health treatments in the near future? I mean, I would say clinically, I use it a fair amount just in terms of how often people focus. And so one of my philosophies, and whether I get to writing a book about it or not, is, as I call, quest, not test. And by that, I mean, so often, whether it's anger problems, someone's focused on the driver being an asshole in front of them, whether it's sadness, whether it's social anxiety, whether it's a whole range of mental health problems, come about because we make it a test that this is all about, well, it's not fair that he's driving like a jerk. Or in a social anxiety situation, we become focused on how we're being evaluated and we make a test out of it rather than just focusing on the performance itself. So the quest, not test, is actually saying, get out of your left brain, stop focusing on the details or what's happening or not happening in this individual situation and making a test out of it. And step back and ask yourself, what is the bigger overarching goal? What am I working for? What am I striving for? What are my values aligned with? And how do I get back to moving in that direction rather than seeing any specific incident, event, short of it killing you, as preventing you from getting there? So I would say right now, there immediately, that has direct clinical implications. That's separate from, there are certainly people using all sorts of and developing neuromodulatory devices, which may or may not preferentially activate left prefrontal cortex versus right prefrontal cortex and may reduce symptomatology that way. So Tom asks, what's my stance on the use of SSRIs and SNRIs if the amygdala is hyperaroused in ADHD or PTSD? Is there more harm in this situation? Would an alpha-2 agonist be appropriate if it's more than anxiety? So I'm trying to, sorry, bird just crashed into the window. Thankfully did fly away. So one is, I mean, I do think there's good evidence that the amygdala is hyper involved in many individuals with ADHD or PTSD. I'd say there's group level evidence. Again, in a given individual, does that mean we know their amygdala is hyper aroused? I guess my initial thought is I tend to not tell people, oh, we know this is happening because your amygdala is aroused. It makes sense. But one, that's almost always simplistic. And two, unless we do have direct evidence of that in you, then it's hard to know what's going on because the simple answer there is, emotional overarousal can be hyperactive amygdala or it can be underactive prefrontal cortex. And they're often occurring together, which is primary. Might be philosophical, there might be a clear anatomic reason for one way or the other. I'd say often in a given individual, we're not sorting that out. And whether it even makes a difference clinically may not with certain situations. So, but getting back to the question, medication, I mean, we know we don't have any medications that substantially eradicate most of PTSD symptoms, but some SSRIs and SNRIs do seem to be helpful, and they can be helpful in ADHD when there's concomitant depression and anxiety. Um, yeah, I just, my feeling is that we don't have, might we develop compelling evidence that in the long run, most people are better served by an alpha 2 agonist if they have ADHD and anxiety than treating it with a stimulant plus an SNRI or SSRI? Maybe, but I don't think we have the evidence yet. And even if we have group evidence, that what that might tell us about an individual is hard to know. So I think my training in neuroscience makes me more unwilling to declare that we know what's going to be good for a given individual. That's where I'd leave it. And if there's angles on that to follow up on, let me know. So James Alexander's, what sort of things they can't change if your ADHD patient's focused unproductively on post-diagnosis? So one part of that answer is really easy to answer, and that is unproductive focusing on things on the past that they did because of executive function issues. So I can remember actually Frank, who's the patient who got me interested in ADHD, and I worked with him for 25 years till he moved to a different town, city far away. He would obsess decades later. I mean, he had several younger siblings, and he can remember when he was 6 or 7 being entrusted with his baby sister's carriage and was distracted by a ball or something else, let the carriage roll down the driveway. She fell out, bumped her head. I mean, bled, but there was no concussion or permanent damage or sequelae. He would dwell on that incident years later. And I get that in some way it was emblematic of a whole host of our other issues or problems that had befallen him because he couldn't pay attention to stay on track. But so the easy answer to that question is focusing excessively on past events, particularly when the event themselves didn't lead to serious damage or problems for anyone other than, again, to one's potential self-esteem and view of self in terms of their own capabilities and culpability. So what other things have people are focused on unproductively? Yeah, I'm not coming up with a quick or ready answer. And by that, I'm thinking of all the things people have focused on, some of which were a big struggle, but I think, particularly getting a regular bedtime, particularly finding tools that help them get out of the house on time or remember to get out of the house on time. Particularly, I'd say there's things that continue to be big struggles, but that most people with ADHD can find some reasonable accommodations, efficiencies, approaches that do improve where they were before their diagnosis and before their treatment. I guess another way of asking the question, are there realms of ADHD that aren't touched or improved by any of our current treatments? And I'll think more about that one. Yeah, so good question, but so I need to think more. I can't answer more off the top of my head. So Tom brings up guanfacine, the alpha 2 noradrenergic agonist, is a game changer. It's like being wrapped in a cozy blanket. Vyvanse is great, but guanfacine impressed him the most for helping. Marco asks, why are there so many side effects to brain meds? I'd start out with, I don't think it's at all specific or just brain meds. I'd say almost everything we have, whether it's blood pressure medications or ulcer medications or diabetes medications, have a whole host of side effects. And the most simplistic answer is that because of evolutionary history, the brain and the body tend to reuse lots of chemicals in different ways. So the targets of our drugs are often involved in multiple pathways, is a simple answer. And, we pretend dopamine is the neurotransmitter for reward and motivation, but it's involved in so many other things. So we don't yet have narrow enough tools that are only affecting one set of dopamine receptors or process circuits in part of the brain. We're affecting dopamine everywhere. And again, dopamine, norepinephrine, and serotonin have sort of been picked on or focused on for 50, 60 years. Each of those systems is a tiny, tiny system representing less than 1% of the nerves, but they're really potent systems because they modulate and affect multiple other systems in the brain. So even if we find one narrow system and only are banging on that, kind of like the toe bone's connected to the shin bone, and I'm getting my anatomy mixed up, it's all connected. So, or as John Muir talked about the environment, it's all web, and we can't just pick one strand and think that it's only going to affect one element. These circuits and systems are interconnected. So James Alexander is asking a follow-up. Sorry. About the patients I've known who have died from insufficiently treated ADHD, how did their deaths come about other than suicide? So one, and I think I've also mentioned him in the book, he was actually the son of a patient, and I'm trying to not provide too many details. A horrible, parents were living apart. He actually was so out of control. He assaulted his mother physically when he was 11 or 12, was taken to the emergency room because he was out of control. I will target the Kaiser system because that's what he was part of. Kaiser is notoriously bad for mental health. And I will say that even though I know and respect psychiatrists, psychologists, social workers that are within their system, but as a system as a whole, it's been notoriously bad and throughout California and sued multiple times. Anyway, had some initial, very brief, after the ER visit, I think it was 6 weeks before a social worker evaluated him, felt he had ADHD, and made an appointment with the child psychiatrist who was just about to go on vacation. So I think the child psychiatrist saw him once and then not another appointment. So his first in-depth treatment opportunity didn't come till 3 or 4 months after a major family crisis. And over the next several years, the treatment for ADHD, the kid did respond well to medication when he took it, but the treatment was so sporadic. I would argue that the initial message was what you're dealing with is who cares? It's not important enough for us to be treating it. Anyway, kid grew up abusing street drugs, involved in substantial criminality, did have a criminal record, had a warrant out for his arrest, was in a parking lot, came back to his car, and I think sort of noticed with his girlfriend, agents were surveilling his car when he got into it, and rather than just surrendering to police, and this is again a crowded parking lot, he stepped on the gas, hitting one of the officers, and died in a fusillade of bullets from the police. I mean, clearly lots of factors led into this, but I would say fundamentally to me, one, his reaction at the time of impulsively, I can get out of this, was an ADD reaction. But two, what led up to it was negligence and minimizing of the seriousness of his ADHD. So that's, again, a dramatic one. I mean, short of death, I've had people who had health conditions which they ignored. I mean, one person with urinary problems who turned out had when they finally got diagnosed, had prostate cancer, was metastasized throughout their body and died of that. I think if they had, so that's an indirect way ADHD led to a premature death. I've also had people who've had other conditions that were amenable to surgeries that delayed so long on their surgeries that they wound up with permanent disabilities, which hastened their death. So, I mean, the big one is accidents. I can't think of specific patients right now, but I've certainly had patients whose family members, a guy whose father in his 70s was up cleaning the roof and fell off the roof and died many days later from his falls. And actually, in that situation, understanding his ADHD and understanding that his dad had ADHD, and that explained sort of a whole rash of sort of uncommon, rare, bizarre, but serious accidents that father and multiple family members, even though in some ways they were quite handy and industrial and engaged in a lot of manual activity, but had a surplus of accidents in that family, and learning it just wasn't a curse or bad luck or a stupid incident at the time of reaching for something that was just out of reach and miscalculating. So those are deaths I would attribute to ADHD. So Huav asks, what are my thoughts on Focalone XR as an alternative to Concerta? And I hope it doesn't sound flippant, is that if it works for you, great. So there are more than a dozen different tweaks on methylphenidate long-acting products and shifting ratios between L and R isomers and allowing a little bit out at a given time and a greater amount at a different time. I'd say in my clinical practice, Concerta, part of it I think is the osmotic delivery system. Part of it is that it was well designed. Of the methylphenidate products, that one, in my impression, sort of has jumped out as being a very reasonable first-rate choice. I've had people who had good responses to any number of other agents, but I think most of the manipulations and tweakings there are more marketing attempts than that any of them are substantially different or breakthroughs, with one exception. And that, I would say, is, I'm blanking on its name. It's the one you take the night before. Jornay, Jornay in America. That, I think, in some ways as a delayed 10 hours before it starts acting, that allows people to take it the night before and be up and going when they wake up in the morning. That, I think, is a substantially different, doesn't work or isn't a great advantage for everyone, but that to me is a substantial difference, and most of the others are minor tweaks. Again, that doesn't mean a given individual might not have much better effects on Focalone than Concerta or Focalone XR. But again, none of them stand out as, for most individuals, being a better choice. Anthony Howell says, I started supplementing with agmatine sulfate for cardiovascular health, but I believe I'm receiving mental health benefits as well. Can you speak to this supplement at all? And the simple answer is I am writing it down. And no, I don't know anything about that, and I'm hoping it's spelled correctly. it's triggering thoughts about melatonin, which was never approved in the US, but it's a melatonin-derived antidepressant and approved in parts of Europe, but agmatine. So no, I will do my research, and if I can find anything worth talking about, we'll talk about it. Max is forwarding another question by Designer Study. He says, I'm trusting my thinking more. Before, I would always have an inner monologue, like I was rehearsing a speech in my head. Could it be that I'm giving more value to my right brain? That's a plausible explanation. So I'll just leave that at that. Yeah, that makes sense. How that came about would be interesting to me, but and Huav is following up on the focal and concerta question. And they are talking about the challenges presented with concerta generics for some patients. Could focal and actually be a viable option if response to generics is subpar? So yes, I mean, so there is one value to going with a specific product that, at least at this time, is only available as a branded product, because then you are only dealing with one manufacturer, and not only just one manufacturer, but one whose name and image is associated with their product. I mean, one of the downsides of generics is that although on the label, at least in the US, you can tell which company made it, most people aren't looking or paying attention. So there's less accountability and responsibility, I think, felt by the generic makers. So yes, again, particularly if you had a good response to focal and XR, then you are highly likely to get that same benefit from the next batch. And one of the difficulties with Concerta is that and most of what's available out there is generic, and what insurers are covering is generic, it may be the exact same product by the same generic manufacturer the next month. It may be completely different. And one of the astounding things to me is, again, part of what makes Concerta special is the osmotic delivery system. Generic versions of Concerta don't even have to use that delivery system, as long as their parameters for how much is absorbed, how quickly it's absorbed, are generally close to the brand name. So James Alexander asks, and I'm looking at it's 11, so I'll try to wrap up. Why doesn't the social impairment aspect of Asperger's appear in isolation from other associated symptoms in more people? It seems like there'd be many more people with pathological social impairment than with co-occurring repetitive behaviors or overly narrow interests. Yeah, so I don't know if the question is, I mean, one way of answering the question is with the follow-up question as to whether, so at least in DSM-5, the core elements of autism spectrum are social impairment. And again, that's not just anxiety, that's impairment in reading and processing social information, and repetitive, recurring stereotypical behaviors, and overly narrow interest focus. I mean, it's one explanation is that there is ultimately a single brain system function that is impaired, that is contributing to all three of these, and that's why they are found together. And the other is that these are separable entities that are co-occurring for some other reason. If invariably we're finding they're connected, then that more strongly suggests some common origin. So Max is has brought up the sorry, the question and answer jumps around when I'm trying to scan it and I'm trying to jump at. So Max, thanks Max for bringing up the 1 gram psychopathology theory or element. So Tainer asks, what do I have thoughts on some of these new anti-SSRI and benzo YouTube channels? One is, maybe YouTube doesn't want me to be saying this. I have produced orders of magnitude more hours and spent more time on my own channel than I do reading or watching, listening to other people's channels. It's just not how I gather information usually. So I don't have much intimate detail with them. I mean, I've heard clips of them, and I think much of it is not different than what people are saying in writing. I think fundamentally, even though some of them are doctors, most of them have no understanding of science, epidemiology. I mean, are these perfect medications? Absolutely not. Is the net benefit to risk at a general population level? Have these been beneficial drugs? I think that's hard to deny. Do they have significant problems? Yes. Do they lack benefit? Absolutely not. I mean, you'd have to ask why dogs respond to them. It's not placebo effects there. Why we can see brain. I mean, the fundamental argument that seems so bizarre to me is they're arguing these are horrible, powerful drugs that destroy brains, and these are completely ineffective drugs that have no beneficial input in the brain. Really? Is that? I mean, that's possible. A drug substance would do that, but not that you would be able to convince millions of people to do that if that's how it worked. So Mark is saying methylphenidate doesn't work. Amphetamine and bupropion cause chest pain. Chest pain is not anxiety, nor is a cardiac issue. It's likely caused by lung scarring. Any suggestions in sertraline, modafinil? Sertraline wouldn't be expected to have much impact on ADHD symptoms in general. I'd say most of the other drugs that activate sympathetic nervous system, like Cymbalta or atomoxetine, would be likely to trigger that. And I would, in general, again, I don't know your specific case, even if there is lung scarring, if it's not chronically causing an issue, then there's some interaction between, again, it sounds like sympathetic activation and the symptom you experience as chest pain. And almost certainly there is some decoupling through CBT processes, brain, that would be helpful or effective in some part of it. A drug like modafinil, which in most people does not seem to have primarily sympathomimetic function, should be likely to help. And guanfacine, again, also may well be not triggering that as a response. So James Alexander asks if alpha agonists fail to stop excessive pacing. My approach there would be to ask what the feeling is like in the person who's experiencing that, and secondarily, what they think it's achieving or doing for them, and thirdly, what they think may help alleviate it. That's where my general approach would go. So that. Carol is drawn to activities that I anticipate will release dopamine, but they keep me in a loop of being distracted from longer-term objectives. Yeah, I mean, that in some ways is a fundamental problem of ADHD, is how do you change the reward balance between something that looks immediately interesting versus something that fits a longer term objective. And medications may help a little with that, or help more often with getting engaged in the moment with a longer term objective that may be hard to start. But I'd say more fundamentally, cognitive behavioral strategies for how to, and the simple one is often visual images are helpful for people with ADHD. So if you have a picture of what this longer term, let's say better physical fitness is your objective. If you take two pictures of yourself, one at your physical peak and one at what you don't like about your body now, and have them there and visible, then you might be able to look at that and say, wait a minute, I want to keep working for that better body, what I'm considering better. That's a judgment call, I know. And that may help you to not engage in watching the cat video or catching up on the women's basketball scores. So James Alexander asks, the issue with NSAIDs and rotting your gut, is it the actual acute interaction with the gut lining, or because of their systematic effects? Are the new coated tablets for aspirin actually safer than the old ones? So my answer is sort of somewhere in between. I don't know that it's necessarily direct contact. I mean, there are photos and examples of endoscopy where a pill is eroded. Direct contact was a problem, but it's more a local context that the effect these have on inflammatory processes, coagulatory processes in the local area of the GI. So that's maybe less than their whole body systematic effects. I do not know if the research supports or doesn't support whether coated aspirins are more safe. That's an empiric question. I don't have the data at the top of my hands. So Diane is surprised that I spoke out about Kaiser. Again, I do know people who are very good, competent clinicians in their system and have for years, but I worked for 30 plus years in Northern California. There was a pattern of, one thing that they were sued for repeatedly was allowing social workers and people without adequate training to essentially dictate prescriptions. So the social worker would make an evaluation, would say this person should be on an SSRI. The psychiatrist would sign off on it. And every 5 or 6 years, they would be sued for that. In Northern California alone, not just nationwide, they would maybe clamp down on that practice. And then, given it seemed to be an institutional practice, it would sort of creep up more and more. And then they'd run into bad examples. So other than, I do have other specific horror stories or anecdotes. And things like ADHD, they were notorious in Northern California for being reluctant to prescribe stimulants and requiring educational courses. Now, I think education can be powerfully helpful and useful in ADHD, but having a blanket prohibition on any prescribing unless someone took that course, what you'd really want to do is evaluate, does someone have the skills and the tools you're trying to teach already? If they do, then don't insist on the course. Yeah. So David Butcher, child is taking atomoxetine and clonidine with little improvement. What would be a logical next medicine to add or subtract next? Thank you. So again, I can't make specific recommendations. My approach is always, if there's any inkling of benefit from what's currently going on, would be to modify what's currently going on before jumping ship to going something else. If there's no improvement at all, then it might make sense if you've exhausted the range of dosages. So the other angle, and some of this is in my talk on high-dose medications, don't pay attention to what the high dose are or what the limits are. Pay attention to what's happening to your child. If they're having absolutely no side effects and minimal benefits, even if they're at the top of the recommended dosage range, it usually makes sense to go above the top. If they're having side effects or symptoms, then absolutely don't push it. But look at the physiologic response of the individual person, not group numbers, which are, again, they're guidelines or recommendations, but the FDA themselves says these are recommendations. We know some people will need more and some will need less in these guidelines. And Max is also putting out a blurb for the Growth Minds podcast. A few weeks ago, it was a discussion on ADHD. And Max also provides the link to the high-dose medications. The focus there are stimulants, but the message is the same for pretty much all classes. So I can empathize with Diane, who's, whatever's in the chart at Kaiser, when her doctor retires, the new doctor is going to just accept all the diagnoses without evaluating them for themselves. So a reminder that there is the Reddit channel if you want to engage in more extensive discussions with fellow viewers, listeners. I'll be back next week, but 2 weeks from now, I won't be here. And stay healthy, stay happy. And if you think it's a crazy world, that's probably an accurate perception. But we have ways to cope with that. That's all.